Recording has started.
We'll just do some quick housekeeping. If everybody could put themselves on mute and utilize the chat, we'll leave time for questions at the end. And I'm going to hand it over to Brooke to take it away.
All right. Thank you, Nicole. My name is Brooke Feldman, she, her pronouns. Excited to facilitate this panel discussion today. So thank you for the Penn Outreach team for posting this, and for everyone that hopped on. It's nice to see faces and names I recognize, and it's always even nicer to see some folks that I don't recognize, because we're all about not preaching to the choir, right? And so today we're talking about harm reduction across the entire continuum of care. And so we have three great panelists that we'll get to, but just wanted to kind of, give an overview of what we'll be talking about and ground us all in the same, sort of the same idea of what we're talking about when we talk about harm reduction across the entire continuum of care. So today you'll get to hear from, Clayton Rowley with Prevention Point, and how harm reduction looks in a community setting, in a harm reduction organization. Then also hear from Dr. Chertok about emergency department, primary care and harm reduction in primary care setting. And then Brittany Salerno will talk about what harm reduction looks like in emergency department settings. And so I think we have a good little array of what harm reduction looks like in a variety of settings. And if you're like, wait, I don't work in a community organization or an emergency department or a primary care setting, maybe this isn't for me. I think that the theme that we want to really get across through the entire panel discussion today is that harm reduction principles and practices really are universally applied in any setting. And so even if you're not in one of the three settings that you see on the screen, pretty confident that you'll hear something that you can use in whatever setting that you work in or are aspiring to work in. So just to start us off, before we hear from our first panelist, Clayton, I just wanted to kind of ground us in what we mean when we talk about like harm reduction. I think that, sometimes we get associations to certain words and terms, and we think of a particular thing. But when we're talking about harm reduction, especially for today, we're really talking about this approach, about this way that we engage with people who use drugs or are living with a substance use disorder. And that, when we think about these principles, it really applies in all of our interactions, in all of our settings. It's not just syringe service programs. Harm reduction isn't just overdose prevention sites. Harm reduction really is the way that we work with folks. And so I'm not going to go through all these principles because that would take the entire webinar or the panel time up. But what you see on the screen is available on the National Harm Reduction Coalition website. And these are really the principles that we think of when we think about what does harm reduction look like. And so we recognize that people have always and will always seek to alter their consciousness with the use of with drugs in some form or fashion. And that, harm reduction is about seeking to minimize the harms that are associated with certain substance use. And rather than focusing on abstinence as the outcome, like as, what is the only marker of success, right? Really recognizing that quality of life for the individual and for communities is really the goal. And for each of us, that might look different. For some of us, that means total abstinence, that if I put drugs into my body, quality of life goes out the window. I've tried to moderate, it hasn't worked, right? That might be for some of us. And for others, it can look like, that maybe the actual substance use remains exactly the same, but that other things are improving, like living conditions or employment or social support, whatever it might be. So really not focusing on abstinence as the outcome, but instead quality of life. And really, I think before we get into hearing what this looks like in real life settings, recognizing that people who use drugs, right, are the experts on themselves and what their needs are, what their goals are, and that our role in the service settings that we work in is really to support folks with whatever it is that their goal is to improve their quality of life. And sometimes that could look very different than maybe what we think should be the goal, right? That's human. We're all humans, unless there's any robots that joined in today. But really recognizing that, we're meeting people where they're at, supporting them with their goals, not focusing on substance use or abstinence, right? But really, what can we do to support you and having the kind of life that you want to have. So that's like the short and condensed version, but encourage everybody to not only check out these principles, but really, even print them out, keep them close, because for many of us, for everyone you'll hear from today, what you see on the screen is really what drives our work and what we mean when we talk about harm reduction. So without that, I'm going to shut up now and pass it over to Clayton Ruley, who is amazing, to kind of kick us off with talk about what harm reduction looks like at the community level and with Prevention Point Philadelphia Services. So all you, Clayton.
Thank you for the introduction, Brooke. Can everyone hear me?
Yes.
Yes? Okay, great. Thank you for the introduction, Brooke. I'm very glad to be on this panel and be on the panel with, some great friends and coworkers in the line of harm reduction. When we talk about harm reduction, we're talking about in the experience of Prevention Point being the baseline for folks to receive help and get linked to care as far as warm handoffs go and continuum of care. I think it's really important to recognize that, I think every opportunity that you have to engage with participants, guests, clients that you work with should be an opportunity to hand them off to another program, whether that's internally or externally. There should be no siloing of services where one doesn't talk to the other. And I think Prevention Point Philadelphia, and I'm clearly biased, but I think Prevention Point Philadelphia has done a great job of having a continuum and collaborative set of services that engage with each other regularly and link each other to care inside our services, but also externally. We can go to the next slide. So I just wanted to share this quote from John Ehrlichman, who was a member of the Richard Nixon's, domestic policy chief. And this is speaking about the war on drugs, because I think it's important to note that, we are doing the work we do in large part due to the fact that there has been a war on people that has been misquoted as being a war on drugs. Drugs have remained. People have been taken out of homes. People have been, killed or died. People have had less of a high quality of life because of this war on people disguised as a war on drugs. And some people may not think that it's intentional, but I want to prove that at least in this case, and we know several other more, it was clearly focused on by certain administrations in the United States government. So John says, you want to know what this is really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or blacks, but by getting the public to associate the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt their communities, we could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So this is a very powerful statement from someone who was high up in the Nixon campaign. We think about the war on drugs. I think a lot of us who are old enough will think about, Nixon, Ronald Reagan, but we can also go back in time, think about how we treated, prohibition in the 1920s. Think about how we treated folks who were coming over from Asia and opium when they helped build our railroads and many other things in America. Think how we sensationalize the negative aspects of marijuana, reefer madness, and it goes on and on. The war on drugs has been punitive. It has not been typically rehabilitative, or at least not the way it should have been. And this is what we are fighting against. Next slide. Prevention Point is a nonprofit public health organization committed to promoting health, empowerment, and safety for communities affected by drug use and poverty. Next. Each and every individual is unique and valuable, and we have a vision that we're going to treat people with a non-judgmental stance because we know that everyone deserves a clean slate. We know that to get respect, you have to give respect. We know to get trust from folks, you have to give trust to people. We know that we're in this work together, as providers together, as the provider to a participant. We're in together, but it is about and individuals having the tools and resources to have individual problem solving, and we fully support that and encourage that. We want to be advocates for folks on the micro level. So, working with individuals in smaller groups, but know that we have to do it also on the macro level. So on the big level, on a policy level, societal level. We know that a big difference between the work that we do in harm reduction and the work that's been done previously, and in some cases still to this day, is we offer flexibility for the people that come into our doors. Whether it's around chances to succeed and fail, whether it's around timing, like appointments wise, we are always thinking about getting more people in the door, not trying to always give lessons by saying 3 strikes and you're out, or you came late, so don't come back until tomorrow or, next week. And I would also say, lastly, we try to get all of our cues for what needs to happen as far as service provision goes from the bottom up and not the top down. We want to listen to the people that are, experiencing the services, that have experienced the services. And in general, that has guided our practice at Prevention Point. Next slide.
Hey,
Next slide. Oh, thank you. So we want
he's
to do
down
our
here.
service. We want to do our services in a way that always promotes safety, always tries to greet everyone in a welcoming and inclusive manner, is non-judgmental, meets people where they are is really important. If anyone is not on mute, please put yourself on mute, please. Thank you. Continuing, respects every individual, promotes human rights, and contributes to advancing social and economic justice. Next slide, please. Basically, our goals are to prevent disease. We started as a syringe service program in 1992 under executive order from Mayor Ed Rendell. We opened our doors in November of 92. Before we were open, the new cases of HIV were at 48.5% of the total new cases of HIV in total. And so the focus was, let's do what's worked in Europe. Let's do that what's worked, at least for the first time in the U.S. in Olympia, Washington in 1988, to give out clean syringes and supplies and also other resources and education so folks can reduce harm. Obviously, as we've gotten larger, it's more than just HIV and Hep C. It's anything that we can, see and help people get referred to. So certainly HIV, certainly all the hepatitises, certainly STIs. We want to be a place that folks can get tested, treated, and if they can't get treated with us, they can certainly get treated or tested, for that matter, in other partners, locations. We want to be a source of information. We want to be a bridge to healthcare. We want to be a bridge to housing, and we want to be a bridge to treatment-related services, whether that's internal or external. And I'm proud to say that folks that are on this call have been partners with us for a very long time, and that's what I'm talking about when we say that warm handoff. We're not trying to give the participants that we work with and we have built a trust with to folks who don't know how to handle and deal with the people that we work with and work for. I do say those terms interchangeably. We work for our participants. We work for our coworkers. We work for our administration. We work for the community. We work with our participants. We work with our, coworkers. We work with our administration. We work with our community. Next slide, please. We do this practicing harm reduction. Brooke gave you a intro into harm reduction. I'm going to share my definition that I use often. Harm reduction is a set of practical public health strategies designed to reduce negative consequences of risky behaviors, including drug use and sex work, and promote healthy individuals and communities without necessarily reducing drug use. It's normally italicized in my slides. We are not an abstinence-only model of an organization. There are plenty of them with varied levels of success, but many failures. As Brooke mentioned earlier, it's really important to understand that for some folks, abstinence-only model will never work for them. It's really around safety. It's around empowerment. It's around meeting people where they are. Next slide. We recognize that there's a host of reasons that people gravitate towards doing these behaviors, these activities. Poverty, class, racism, social isolation, past trauma, sexually based discrimination, and other social inequities. I talked about the war on drugs being a war on people. Have we ever really had a war on poverty? Have we had a war on racism? People want to blame the drugs. They want to blame the risky behaviors. But when we think about it, The drug use, the sex work, the other risky behaviors are a symptom of a larger problem that I think that we as a country need to recognize more than any other country that I can think of. Well, there are a few that are worse, but surprisingly, despite our success as a country, we still have a long way to go to eradicating poverty, racism, classism, and all some of these other issues that we have. So instead of thinking what people are doing, we need to start questioning why people are doing it and work on that why. I truly believe if we had less people living in poverty in the richest nation in the world, then there would be less folks that feel like they have to engage in risky behaviors to get away. As my friend Elvis Rosado says, typically we got some folks that can take physical vacations, and we have a lot of folks that can't do that because of poverty or just not having the money, being on the grind. So they take chemical vacations, or physical vacations by trying to get away sexually. In some cases, sometimes it's the rubber hits the road, and it's about straight up survival. And in this country, there should be a lot less of that. Harm reduction is realistic. It doesn't doesn't try to minimize, the harms that are associated with risky behaviors. But what it doesn't do is browbeat people into submission that typically doesn't last. If it's not the person's motivational moment, then it's going to be really hard for them to stick through it. Heck, it's hard for folks to stick through it, even if it is their motivational moment. So the consistency that you show in your services and your approach and, how you meet people is the most important thing that I will say harm reduction is about. Next slide, please. So basically, HIV new case rates have dropped significantly with harm reduction and syringe services wherever it's been implemented. In Philadelphia, 48.5% in 1991. We opened up in 92, and then I would say we had a low of 5.6%. Actually, 5.3% in 2014, 5.6% in 2016, and then we saw a sharp increase of 115% as of 2018's numbers. Next slide. We attribute this to the increase of fentanyl in the drug supply. Folks don't realize fentanyl is not your mother and your father's heroin. It's 25 to 100 times stronger than an opioid pain pill or a bag of heroin. It's also something that has a shorter half-life in your body. So first off, it can knock you down and knock you out for good if it's too powerful, and you also have to use it more often. So folks are, daily, if you had someone who used to do 3 or 4 bags of heroin to be stabilized, they're probably doing it more, double the amount of times using fentanyl. And Narcan is needed more often because folks are overdosing because of the potency. So when we say harm reduction is around keeping people alive, keeping people with the resources and tools that they need so that they can get the help, they can get that next level of care, so they can get that warm handoff. Because if you just say let folks go to do whatever they feel like they should do and I don't care about them, there's going to be a lot of bodies on the streets and in homes. So please note that the explosion of HIV and Y Prevention Point, gives out as many syringes as they do and provides the services that we do is in large part due to fentanyl being in the drug supply and the fact that if you're someone who uses intravenous drugs and now you have to use double the amount of times because fentanyl goes out of your system faster and you don't have enough syringes, that means that you're taking a large chance that you're going to contract HIV and Hep C because you're going to wind up particularly having to share syringes with someone who has them because there's not enough syringes on the street. This is not to mention wound care concerns. Next slide. The cost of prevention. We know that the work that we do is around, saving lives, saving livelihoods, but also around saving millions of dollars for the city. We say 8 to 10 cents for the cost of a syringe. Our baseline of 10 syringes and supplies like cookers, cottons, tourniquets, alcohol pads, antiseptic wipes, water with saline, and more. Let's say that's $3 to $5 a bag. Each one, when used correctly, is going to stop someone from contracting HIV or Hep C, which you're going to talk about in the high five figures for Hep C treatment and care to 6 figures to 7 figures for HIV care over the course of a lifetime. Next slide. Basically, the cherry on top of the sundae that I think is an example of this is a George Washington study that came out a couple of years ago. Basically, 10 years of studying Philadelphia said that 10,592 or 92 cases of HIV were avoided by having a syringe service program, i.e. prevention point in Philadelphia. Then they said HIV medication and treatment at the time was around $230,000. If you do the math, basically $240 million annually was saved by having syringe services in Philadelphia, and $2.4 billion over a 10-year period was saved for Philadelphia. Let's note, Philadelphia is the most impoverished city, major city in the country. Let's also note that the 19134 zip code, which Prevention Point has its main office in Kensington, is the most impoverished zip code in the city. So there already is poverty and instability in the neighborhood. Imagine adding 10,592 cases in Philadelphia in total, with a lot of them being in Kensington and needing to pay for HIV care for folks. When you're talking about folks with Medicare or Medicaid, that means us as taxpayers are dealing with that. Next slide, please. These are just some of the list of the programs that we have that I think do a really good job of connecting folks to care. Yes, it starts with the syringe services. That's what we opened with. But it also includes Hep C testing, HIV rapid testing. It includes our overdose prevention program, where we've given out over 10,000 overdose reversal kits and done training in the last year. It includes having a wound care specific clinic. It includes having an acute medical care clinic with providers like Temple, Drexel, Jefferson, and University of Penn. It includes having a ladies' night called Safe Space for the ladies only drop-in. It includes a reproductive health clinic. It includes working with Penn to do mobile MAT induction and treatment called Philly Ride. It includes working with the police to reduce the amount of criminal justice system victims with a diversion program. It includes being a newly organized drug and alcohol assessment center. It includes getting folks who are high risk into care for PrEP, for Hep C, and for HIV. It also includes trying to, avoid folks catching Hep A because there's not enough bathrooms, not enough shelter, not enough hand washing stations in Kensington, and joining the city to do a public restroom program. It includes having a drop-in center, which is really big for connection, whether folks receive care a day later, a week later, a month later. Yes, they don't have to sign for services to be in our doors, but we know it's a gateway to services that I'm mentioning right now. It includes having a medication-assisted treatment program where we do Suboxone and Vivitrol, and it includes our housing program where we have a respite that houses 60 people in Kensington. Not the walk-in respite or shelter that we need in Kensington, but a start to get folks who are chronically homeless into permanent housing. Next slide, please. And thank you very much. And I'm going to pass it off right now to Brittany Salerno. Thank you for listening to me, and hope everyone enjoys the rest of the presentation.
Awesome. Thank you, Clayton. And for folks listening, please feel free to throw questions you have in the chat. We'll make sure we have some time at the end, hopefully, so we can make sure we get everything answered. But if not, we'll make sure that we follow up as well. So use the chat. And next up, we have Brittany Salerno.
Hi, can everyone hear me okay?
Yep.
Perfect. Hi, everyone. I am Brittany Salerno. I'm an emergency buprenorphine outreach coordinator here at Penn Presbyterian Emergency Department. I am also an avid harm reduction and community outreach worker here in Philadelphia, and I'm a founding member of the Philadelphia Overdose Prevention Network, which advocates for safe consumption sites and harm reduction interventions throughout the city of Philadelphia. So I began my journey as the main support person for someone who struggled with opiate use disorder. And throughout those 10 years of my life, I watched addiction completely steal the person that I loved, while also bearing witness to the many fallacies that exist within the treatment system. As a person of privilege with access to things like a phone and transportation, navigating treatment was never clear-cut, which always pushed me to consider those who were not as fortunate as myself and my partner. I spent 8 years in family sessions and Nar-Anon meetings, and through all of that, I was never told about harm reduction, about Narcan, nor about medications for opioid use disorder. One day when I was navigating my loved one from one section of the city recovery house to another section of the city's recovery houses, I was driving down 76 and I looked in my rearview mirror and he was blue. And I had no idea what was happening, so I immediately called 911, and thank God that EMTs arrived in time to administer 8 doses of naloxone, which inevitably saved his life. After his overdose, we went to Penn Presbyterian Emergency Department. And I remember having absolutely no idea what had just happened, if it could happen again, or really what end was up. I just remember that we were in room 26, and on the door there was a flyer about Narcan on it. And I didn't get too much support from the staff at the time in helping me understand all of those questions that I had, not even knowing what the questions were to ask. And at that point in time, we were not even discharged with Narcan. I say this as a testament to how far this hospital system has come since I was here as a loved one 4 years ago. That is all thanks to the clinical champions and advocates who are treating harm reduction as the essential healthcare intervention that it is. After that day, I became heavily involved in harm reduction outreach throughout the city and networking with the incredible advocates that fight every day, many of which are on this call today, for the well-being and rights of people who use drugs by centering drug users' voices. Everything I have learned from people who use drugs have helped me be the advocate that I am today, and I aspire to be the person that I needed back then, and maybe the person that my loved one could have benefited from knowing. So, as harm reduction's presence in the hospital system, I've been privileged to work with such a wonderful team of advocates. We have a harm reduction interest group, and pictured here, you will see our harm reduction brochure. This discusses various treatment options, a QR code for Next Distro, which allows people to scan the code and get Narcan and fentanyl test strips, which have just been recently decriminalized in the city of Philadelphia, long overdue. So you cannot get in trouble for carrying fentanyl test strips. Treatment options, options on how to use drugs more safely, how to protect your veins. And then there's also a call out here about fentanyl being mixed with other drugs. Now, this is super important, especially for our current patient population, because our current overdose rates are disproportionately impacting communities of color. A lot of the patients that come in are not aware that fentanyl are in their pressed oral opioids or in their crack cocaine, which is causing disproportionate overdose rates. This brochure is not only in the emergency department in various hospitals within Penn, but it's now being implemented into our primary care offices as well. And the content in this brochure is going to be implemented into an updated discharge set. So when people come in with opiate use disorder, they will be discharged with this as well. We also provide Narcan at discharge for all of our OUD patients, which is important because, as I said in my personal story, we didn't receive Narcan that day. And as we know, Narcan wears off, right? So having a dose is always good. Simultaneously, we're also working on a risk communication tool to describe the multiple treatment pathways. My experience here in the emergency department, we have a lot of individuals that come in and their chief complaint is detox, without a lot of understanding as far as what that means. A lot of people don't know about medications for opioid use disorder and how buprenorphine is the gold standard, clinically speaking, to effectively treat this disease. So that's harm reduction in empowering an individual to make a well-informed decision for their care, rather than just segueing them into what they think their only option is. Additionally, we are under a partnership with NIDIF, and we are forming a nationally disseminated video and infograph surrounding the dangers of fentanyl and harm reduction strategies that can be used to keep people who use drugs safer. That's in the works. It's not currently published. Next slide, please. So harm reduction is absolutely healthcare. 1 in 5 non-fatal overdoses that visit an emergency department lose their battle within just 1 year of that baseline visit. To put that in context, I usually see about 1 non-fatal overdose during my shifts, and I work 5 days a week, banker hours, traditionally speaking. So 1 of the 5 individuals that I meet in a week's time will not be here in a year. And I think it's safe to say that that number is likely increasing, considering our overdose rates that have also been increasing. I have a wonderful privilege of being able to engage with all substance use patients, not just opioid use disorder, as an advocate to support and encourage them to feel safe returning to this hospital. In terms of harm reduction, understanding that when someone comes in with an abscess or an infection or is sick for anything, that treatment may not be what they want that day, and that's totally fine. So I give them my card so they know that they have an advocate waiting for them at the other side of the doorway, so they're not here by themselves. An example of that is I had a trauma patient come in a couple weeks ago with a head wound who would need to return to the emergency department to have his wound redressed in just a couple of days. So I gave him my card so he could give it to the front desk, so when he does return, he knows he's not by himself. No pushing of treatment whatsoever, but just so he knows that somebody is here, right? That somebody is going to advocate for them and keep them company, get them ginger ale and crackers, whatever it may be. With that being said, I think we should also recognize how hard it is for people who are pursuing treatment or just individuals who use drugs. What that experience may be like when you're looking stigma right in the eyes. You know, people come into that door and they're greeted with security and have to go through a security system to enter just for general health care. And that's very triggering for a lot of individuals. So just being an advocate and meeting somebody at that front door and walking them through that process is just such a wonderful privilege. So in closing, by meeting each person exactly where they are, in a safe, non-judgmental space, you can help foster trust where stigma would otherwise be occupied. And in doing that, you're creating a safe space. So if they choose to pursue recovery, whatever that means to them, you have created a safe space for them to do that in. So I'm going to pass it to Dr. Shertok next.
Hi, sound check. Brooke, we're okay?
You're good.
Okay. Hi, everyone. Thank you so much for inviting me to be on this panel. I am taking furious notes on my other panelists' comments, but I am excited to just talk about how the harm reduction philosophies and values play out in our primary care practice. I'm a family doctor, and first and foremost, I'm a primary care doctor, but have increasingly become involved in the addiction program that we run at Penn Family Care, which is a large outpatient primary care practice at Penn Medicine. Next slide, please. So I'm going to talk about how harm reduction plays out in a couple different areas in primary care. So these are the topics that I'll cover. So for next slide, please. Alex, next slide, please. Thank you. I'm going to go fast so we have time for questions. This has been highlighted so much by what Clayton and Brittany mentioned, but the relationship and the safe space is everything. We think of this as most important in all of primary care, but particularly for this group of this population who has felt stigma at any institution they've encountered, providing that open, both in our own demeanor and in the way that our office welcomes these patients is extremely important. And I think everything that we do after that to help care for our patients stems from the relationship that we're able to establish. And so all of those key values that Prevention Point mentioned earlier on, those are the things that we need to be doing in our primary care setting to create the foundation of a relationship. Next slide, please. In primary care, harm reduction is something I think it's a term that was used initially in people who use drugs, but it is something that we use all the time in every encounter that we have with patients. When we think of someone who has any uncontrolled chronic illness, we have to figure out where they're at, what they're interested, what treatments feel realistic and feasible to them, what works for them, what side effects they can tolerate, what they think is they can do. And so that is something that we do all the time in primary care, but that works especially well with this group. So motivational interviewing is a particular behavioral technique we use in order to help people figure out where they're at and also help them move along the continuum towards better health behaviors. The next thing is trauma. Oh, last slide. I just want to highlight just trauma-informed care. This is something that we think a lot about. We know this is a group of people who've experienced significant trauma in their life, and we know that the way that we talk to people, the way that we display our environment, the way that they're treated from every step of the way, from the elevator through to the exam room, makes a huge difference. So we have to think really carefully about that. And then I also think very specifically about the language that we use, both in talking to our patients, but also in the medical record and documentation. There's so much stigma that gets carried through actually the written record. Next slide, please. The next way that we use harm reduction in primary care is by highlighting the team and the particular elements of there's so many important members of our team, but I specifically want to highlight our certified recovery specialists who have trained me and taught us so much about harm reduction, but are able to be this key linkage to our patients in discussing these issues of harm reduction in a way that makes the most sense to our patients. So using the team, and we are so privileged to have a large team in our practice, really allows us to implement these harm reduction practices. Next slide, please. The next way this plays out in primary care is practical strategies. So medical care for our patients who use drugs is to really, as in other areas of medicine, figure out what's going on, where we can intervene to promote safety. And so any, of course, like explicit medical complications of drug use, we will manage and treat, but we also need to think really carefully about screening and treating for infectious diseases. We think about PrEP or pre-exposure prophylaxis for HIV for someone who has ongoing injection drug use and is at high risk of HIV due to poor access to syringe exchange. We can offer them medication to prevent HIV, which we do in our office. Vaccination, there's an outbreak of hepatitis A that was alluded to. We are vaccinating really broadly. We have like a hepatitis A vaccine day. COVID vaccines are extremely important now, of course, as a very high risk population. Narcan, we review very carefully safer injection practices. Things that Brittany alluded to on her handout, but we really go through that with our patients. And then, of course, we want to create that environment, that relationship, that place where someone feels like they can come back if they are interested in additional treatment. Next slide, please. And then medication for opioid use disorder, if this is in the patient's list of things that they are interested in, we provide that in the primary care setting. This has a number of this setting, primary care setting, is extremely helpful to provide some harm reduction. There are some ways that harm reduction, can play out in the primary care setting. So firstly, what we try to do is provide flexible scheduling and to really be if someone is able to get through all those steps it takes to show up, if they come late, we want to see them. It allows us in primary care to decouple the medication treatment of substance use from the behavioral health and addiction treatment. And so patients can choose what pieces of care feel right to them at the moment. We very strongly think that to protect our patients, we need to continue the medication as long as they're deriving benefit from it. So that means even if someone has ongoing use, I know that's not new to many people on this call, but there are still lots of places where patients don't get continued treatment if they have ongoing substance use. And then, of course, always opening the door to come back. Next slide, please. And then finally, in primary, one of the ways that I see harm reduction play on primary care is to leave the office. And so really proud of working with the Prevention Point team on their mobile overdose unit and providing low barrier buprenorphine starts to patients in the West Philadelphia community, which is where we were the first year, and then linking them to care in our primary care practice. And so explicitly finding and welcoming patients to join our group, both for medications for opioid use disorder, if that's what works for them, but also for general primary. Next slide, please. I do have some information about the patients we see in our office. We can skip this slide. If there's questions, we can refer to it. And then a very, very quick story about a patient that I think highlights sort of how harm reduction can play out in our primary care setting. But just to share a patient story, of LS who's been my patient now for about 3 years. And essentially, it's a story of someone who has severe mental illness and severe substance use who has been in and out of care with us at Penn Family Care for about 3 years, multiple attempts at starting and stopping medication, and including lots of creative ways of recently trying microdose induction, Sublocade, really trying to get her engaged in care. What this really highlights to me is that in the primary care setting, through these harm reduction principles, we're able to maintain this relationship, provide needed medical care, and being available for the patient for LS wherever she is in her. Next slide, please. So the key points I really want to highlight are the first, this seems so obvious, and yet so many times this is not what people face in our healthcare system. People who use drugs need and deserve treatment of their other medical and psychiatric conditions. There are so many barriers that they face to receiving routine medical care, and we need to be the place that provides it. Of course, everybody on this call, I think, is aware that abstinence is not the only or the most important treatment outcome for most of our people, and we need to really understand what their goals are and to provide the support they need to reach them. I also think that the relationship itself with a positive support person, whether it be the certified recovery specialist, the medical assistant, the nurse, or the provider, can be itself therapeutic and itself an important endpoint. And then finally, every single interaction, every email from a patient, phone call from a patient, in-person interaction is an opportunity to review different harm reduction practices. So that is the end of my section. Brooke, I think you have some next steps to share.
Yeah, thank you so much. And I actually go back to say, the last point that was made, which I think is something that we heard throughout all of the panelists, right? That every interaction is an opportunity to review or practice harm reduction practices, right? And I love how, the idea of that somebody may not want anything you have to offer right now, right? Or what they came for is totally different than the laundry list of items that you may feel like is super important that they start working on. But every engagement, every opportunity where someone feels, not judged, shamed, stigmatized, discriminated against, punished, etc., is really an opportunity for healing in that moment, and also something that will ensure that people remain engaged along the continuum of care. And so I wanted to just highlight that because I think that was a really important theme throughout all of the panelists. And so wanted to offer a few ways that you can get involved while we also open it up for questions. Just really quickly, you heard Clayton talking about syringe service programs, and while in Philadelphia and Pittsburgh there are sanctions that allow for them to be legal, at the state level and in the rest of Pennsylvania, they still remain illegal, just like fentanyl test strips. And so we are having a rally on September 29th next month at the state capitol. We're going to do some legislative education visits so people can talk to elected officials about why certain service programs and harm reduction is so important. And then we're going to have a rally on the front steps with some speakers. In fact, I believe Clayton, who spoke today, is one of the speakers for that event. So if you're interested in attending the rally, or if you can't attend that day but want to be part of getting the word out and supporting it, then please contact Carla Safransky. The email address is up there. Brittany mentioned the Philadelphia Overdose Prevention Network. So there's lots of opportunities to get involved at the level you feel comfortable with. And so you can check out the website for the Philadelphia Overdose Prevention Network, lovingly known as POPPIN, to get involved that way. And then recently, we just launched, meaning Carla Safransky and myself, had the opportunity to launch a new statewide harm reduction advocacy organization, which is just getting started and is getting started with a lot of listening to folks across the city and state about what is needed from a statewide harm reduction organization. So Carl and I just recently co-founded it. It's the PA Harm Reduction Network, and we have social media up and running, very skeleton-like. So if you want to be involved from the very get-go with the statewide harm reduction, advocacy effort looks like, then please follow the PA Harm Reduction Network on social media. And then Next Distro, as Brittany mentioned, is listed on the brochure that folks get if they walk into Penn. Next Distro has a ton of resources that are available, including, really importantly, mail-based naloxone and fentanyl test strips that are available. So that's another resource to check out, and also opportunities to get involved. And I do believe that you'll have these slides. I saw a question in the chat, so I'm sure someone from the team will send it out. But with that, wanted to kind of leave the last 12 minutes, which is like a miracle when you have a panel, to have time left for questions. Just to open it up for any questions that you may have for the panelists based on what you heard today, or something else that maybe you had a question about that you didn't hear about today. This is your time to shine as panel audience members.
Hi, this is Deb Bard. Can we do this verbally, or would you rather do the chat?
I love hearing voices.
Okay. I talk faster than I type, so that's good. So I have a question for Nicole in the ER. Do you start MAT in the emergency department for folks and then set them up for follow-up afterwards? Once they're released?
I'm not sure if that question's directed at Nicole or myself, but
Brittany,
yes.
I'm sorry.
No, it's totally fine. Nicole's my right-hand girl, so it's totally fine. Yes, we can induct individuals. I lead the buprenorphine outreach here at Presby. So properly assess the patient and what they need for their recovery plan. Get them inducted, not on methadone. Methadone is separate, but as far as Suboxone is concerned, we can absolutely do that based on where they are in their withdrawal and their level of use. And then we like to utilize our recovery specialists to then bridge them into their follow-up care based on their insurance and location and things like that.
Okay, great. And can you give fentanyl test strips or clean syringes through the ED, or do they have to go someplace else for that?
They do have to go somewhere else. With the decriminalization of the fentanyl test strips, I'd like to be optimistic to say maybe that's something we can distribute. But in that brochure that we use that is treated like a tool, it's a communication tool that allows to have that dialogue with patients. We do have access points to the syringe exchange programs and opportunities to get fentanyl test strips, whether through that mail-in service or in person. They're all listed there.
Great.
And Philly has invested in like a pretty robust fentanyl test strip campaign. So in Philly, they're readily available, and I think you can contact anybody who's listed, on the slide here to get connected to the folks at the Philly's Department of Public Health to get access to fentanyl test strips.
Thank you.
You're welcome. I saw a question from Erica. Hey, Erica, about how can treatment providers be encouraged to embrace harm reduction principles in their care and practice, and what are the barriers to do this or to doing this? And I feel like we have our next, lunch webinar topic in that question, right? Because we know that, we have this siloed system, these siloed like parts of the continuum of care, right? Where there's harm reduction, and then there's treatment, and then there's recovery support services. And we really need to move away from this idea that they're all independent of one another, because, people move along that continuum sometimes in the same day, multiple times, right? But when it comes to getting treatment providers to really embrace harm reduction principles and practice, I want to leave it to our panelists, because anyone who knows me knows I could talk for 6 hours about this question. So for any of the panelists, if you want to hop in and kind of address how to get treatment providers to incorporate harm reduction more, great question.
I can just share my brief experience in my practice. I think in general, one of the best ways to change culture and change practice is to do it well, and then be an enthusiastic advocate for it. And that is what really worked in our practice. We started with a small number, one, then two doctors in our practice who were comfortable doing buprenorphine. It's now spread to about 8 providers who do this as part of their regular work, and then everybody who does it in their continuity panels. And I think that culture change can be slow and frustrating along the way, but it feels really good, I think, for us as doctors, at least in primary care, to do what feels right, not to push against our patients and tell them what they need, but to actually listen to our patients and provide them with the support that works. And then our relationships are positive and everything follows from that. So for within my small domain in our practice, that has been a successful strategy.
Awesome, thank you. So Clayton or Brittany, if you wanted to add anything.
Just to echo Dr. Shertock's points, I think it's really important to allocate who your clinical champions are, and maximize on them in any kind of implementation of, be it harm reduction, buprenorphine, anything like that. It just takes one person to speak up and help be the change and motivate others to follow in the lead.
Yes, I agree with what everyone is saying. I can think of a time when, many doctors at University of Penn and some of our other partners spent time at Prevention Point and, learned about harm reduction and what it brought to the table. And those were the same folks that wind up, going back to their organizations and started being voices of change to implement harm reduction practices in the medical setting. So I think it's really important that, it's not just around like what a presentation can do, but actually putting that presentation into practice, and continuing to advocate for our folks on the multiple levels, not just, on what one doctor is going to try to do more, but also as a standard, as a policy, so that it's something that everyone has to fall in line and do.
Excellent, thank you.
I had a question or a comment.
I know that voice, Sterling.
Hey, how are you doing, everyone? I just wanted to know, like, what are people's thoughts on like the role of trauma and people's and how that drives the way people are interacting with others? From what I've seen, there are a lot of people that want to help, but they often, but sometimes they can get in the way. There's a lot of people that want to help. Is there, just like comments on that view on how people help, and then also like how can we help, providers, but also their families. There's a lot of, almost everybody that we know has a death in the family or has a person with addiction, but they're also the same people that say like tough love is the way. And so I'm just wondering, like, what are people's views on this?
Excellent question. We got Clayton, Brittany, or Judy. You want to take on that question? I think that, it's an important one, and there's a lot in that, right? And I think anyone close enough to what's going on cannot walk away without having trauma just mounting at this point.
Yeah, I would.
Go ahead, Clayton.
Yeah, I would definitely say that we're living in traumatic times, particularly with folks who are either firsthand or secondhand, or just community-wise dealing with the trauma that they see on a regular basis. I think that we need to work more towards solutions on a macro level that are trying to avoid that trauma from happening on a regular basis. For instance, I don't think that it's right or fair by people to have to be made to carry Narcan to save lives if we know that there's options that would prevent that from happening, overdosing on the streets from happening as often as it does. We just have to have the willpower as a people to push, in some people's cases, their morality around drugs and drug use aside, and do what's right, by people. Tolls get taken, from not just lay people, but also EMTs and also police and just community members at large when we continue to do things that go against what has worked long term in other places and has been proven to do so. If we don't want to deal with trauma of people on the streets, homeless, we don't want to deal with trauma of trash on the streets. If we don't want to deal with trauma of people using on the streets, we also have to think out of the box and say not what other communities have to do or don't have to do, but what does the communities that this is actually happening and need to help make things better for long term. So obviously, I think taking care of people's health mentally and physically is a big thing on the individual level, but then I also think that there is policy changes that need to happen to ensure that we are doing right, by public health, by harm reduction, and by people, instead of by, over any handshake deal that's happening in the background, um, around like, profit margins and gentrification, for that matter. So I hope people get the gist of what I'm saying. Thanks.
Yeah, and I think, Sterling, I appreciate you saying about rock bottom and how rock bottom oftentimes, unfortunately, leads to somebody's death. And in supporting patients, I've also support family members as well who have questions, who may not understand everything. And I'm going to pull it right back to the principle of harm reduction and meeting people exactly where they are. Understanding where someone is in their own understanding of substance use and validating their emotions and validating the boundaries that they feel that they need to have, but also giving them the solutions to help, right? Like telling them what Narcan is, telling them like when somebody is higher risk for an overdose, and equipping them with at least the access to the information, but without invalidating the boundaries that they may need to set as well.
Excellent. Thank you.
Can I add something? I know we're almost finished, but I think that it's difficult for treatment providers, drug and alcohol treatment providers, to incorporate harm reduction. I think just because of how much that culture needs to change in that regard. If your client isn't achieving abstinence, if your client doesn't go to treatment and follow up on their aftercare plans and stay clean and sober, and do the meetings and all that kind of stuff, if those goals aren't met, then they're not meeting their treatment goals. And so even though out of one side of their mouth they say, well, yes, you need to do client-centered treatment goals and meet each person where they are, what does that really look like on paper? What does that really look like in terms of how much time can you spend with a person in that 15-minute hour or whatever you have, and then have to do the documentation on top of that? I mean, there's a lot of things that are changing systemically in terms of people, of hospitals and medical treatment. I think that's good, but how much of that's being done on a treatment level and through DDEP, I really don't know. Just a thought.
Yeah, it is a lot, right? Just like in hospital settings, and we have some folks that are on today that were part of, sort of trying to move the culture along, right? So that someone like Brittany, 4 years ago walks in and doesn't really get any kind of information or extensive support about how to support her loved one who's there because they overdose, right? Which is really serious. And then 4 years later, is here today. Showing a brochure that now people get, right, and that there's clearly a more harm reduction orientation to the emergency department. And I think what your treatment providers, what's been said already is so true, and what Sterling added in the chat is also true, that not only would there have to be a culture shift, but also a shift in the rules and a shift in what is considered reimbursable versus not reimbursable, and what treatment providers can bill for versus not bill for. So we have a lot of work to do, but definitely please reach out if it's something you're interested in, or if you see opportunities for treatment providers to get some of the information that you got today. And it's certainly something as we go through the process of getting the Pennsylvania Harm Reduction Network up and running, that we look forward to being able to support treatment providers around and to work with DDEP around, because every treatment provider should be harm reduction oriented, and that's just full stop. So we have work to do. But I know we are at that time, and you all squeeze this in probably into very busy days and maybe your lunch. I just wanted to thank everybody who was on the panel. For Dr. Chertok, Clayton, Brittany, thank you so much. And for the Penn Outreach team for putting this together. Alex, who always keeps us, sort of on task and able to present somewhat of a cohesive type of panel discussion. I definitely reach out if there's anything that we can do to support you or answer questions. And I think turn over to Nicole or Alex if there's any other final closing remark.
No, just thank you, everyone. And there is a survey in the chat. If you could fill it out, we'd appreciate it so we know how we can learn and do better. Thanks, everybody, for coming.
Yes, thank you.
Thanks.